Welcome to the Rocky Mountain MS Center's webinar series, Maximizing Lifelong Brain Health in MS. Today's topic is modern treatments for MS, how they work and why some are better for you than others. This presentation features Dr. Dimethyl Fumarate. Dr. Vollmer is a graduate of the Stanford University School of Medicine and a former faculty member at the Yale School of Medicine. He is the Director of Neuroscience Clinical Research at the University of Colorado Anschutz campus, the Medical Director of the Rocky Mountain MS Center, and co-director of the Rocky Mountain MS Center at University of Colorado. We'd like to thank the pharmaceutical companies who have provided patient education grants to support this series, including Genentech, AbbVie, Biogen, and Genzyme. This webinar is scheduled for 45 minutes. After the presentation, we will have about 15 minutes of question and answer from the audience. And with that, we will turn it over to Dr. Vollmer.
Hello, everyone. I hope this talk is useful for you. So we will talk about all the currently approved therapies. And my goal here is basically to help you understand some differences between these medications and use that to discuss these medications with your physicians so that you have the best chance of selecting the agent that's going to work best for you. Sorry, I'm just trying to get the slides to move here. You press it. There we go. Okay, so one thing for you to be aware of is that I do consult for a large number of companies. And if you have any questions about that, feel free to let us know. So these are the companies that I've worked with in the past. Now, the goals are at the Rocky Mountain MS Center for treatment of MS patients is somewhat different than it is in the rest of the world. The primary goal is to reach a definition of no evidence of disease activity, also called NEDA. And NEDA plus means not only we're looking for no evidence of disease activity in terms of relapses, progression of the MS, or new MRI lesions, we're also looking for patients to have sustained disability improvement. In other words, they actually get better over time. For relapsing patients, this means that we need to preserve brain volume to maximize late-life brain health, and I'll talk about that a little bit more. We also want to improve function and their quality of life by year 2 of treatment. That's the definition of NEDA+. For progressive MS, we need to minimize further disability progression by really shutting off any inflammation in the brain as completely as possible. So the reason that the goal is not the same as relapse remitting patients is that we can shut off the inflammation, which slows down progressive MS, but there's 2 aspects to progressive MS. One is ongoing MS inflammation, which we can treat. And the second one is the complication of having normal aging on top of a brain that's been damaged by MS. That's going to require therapies that actually help the brain repair itself, and we are working on those, but we don't have any that we know work for sure at this time. Just to remind you, multiple sclerosis is a disease that's present worldwide. And although National MS Society used to say that the number of MS patients in the United States was about 400,000, in fact, at this time, it appears to be closer to 1 million, and that's based on looking at healthcare records from around the country. It is a worldwide disease, and there's at least 3.4 million people worldwide, and I think that's a gross underestimation period. There are 20 new cases in the U.S. diagnosed annually, and these are mostly in young adults, so people from the age of 14 up to 40, but the mean age of onset is 29 years. So again, this is a disease of primarily young adults, but obviously it stays with them for the rest of their life. It also is a disease that affects primarily women. So about 70% of all patients with MS are female. Why that is, we don't know. Now, untreated MS is a serious disease. And over a lifetime, about 90% of patients will ultimately develop significant disability. 50% will require a cane within 10 years of the onset of their disease. This is untreated. We can fundamentally change these outcomes now, and that's the point of this conversation. Now remember, there are several different forms of MS: relapse-remitting, secondary progressive, and primary progressive. Relapse-remitting means people are having attacks where symptoms get worse, maybe peak after a week or 2, and then gradually get somewhat better, if not completely better. Secondary progressive MS, by definition, are people who started out with relapse-remitting, but over the years then began to move into the progressive phase of disease. And primary progressive MS is patients who never had a clear relapse, simply moved into the progressive phase, usually in the mid-40s, and have a slow loss of function. Now, these patients can have relapses as well, and in fact, a third will have a relapse within 3 years of getting the diagnosis of primary progressive MS. The important point about this is these diseases are not different in terms of what's causing the damage to the brain in terms of MS. The inflammation is the same, both in relapsing forms and progressive forms. But progressive forms have an additional complication. So let me just go back and go why that's important. The size of your brain does actually correlate somewhat with your ability to perform various functions. Our brains are largest at age 5. However, in all of us, just to normal aging, they begin to lose volume about age 35. It's a slow loss, about 0.1%, but it can accelerate, particularly when we are in our 60s and 70s, to about 0.5% per year. In MS, because they have the inflammation in early life, the inflammation causes the brain to shrink at an accelerated rate. And in fact, it is also about 7 times greater than what is seen in normal healthy controls. And that loss of brain volume in early life leads to a situation where the onset of effective aging can come on early. So relapsing and progressive forms of MS have ongoing inflammation that we can treat. However, if we don't treat early, then we're not able to preserve that brain volume, and that will cause an earlier onset of age-related changes later in life. So to maximize brain health, we need to treat as early as we can, as effectively can, and we need to help patients adopt a healthy, active lifestyle like all of us need to adopt in order to maximize our function in later life. So relapses come in 2 forms. One is called a true relapse, which means there's an active area of inflammation in the brain, spinal cord, or optic nerve. These symptoms may come on suddenly, or they may worsen over hours to days, then they peak, and then they may improve over weeks to months. These symptoms tend to last longer than 24 hours and usually last several weeks to months. And there's also pseudo-relapses. These are important because they're not the same problem that a true relapse is. These are symptoms that worsen due to some kind of a stress on the body. That can be a fever, it can be a hot day, it can be a change in weather, it can be a medication. But it's not causing new injury in the brain, it's simply stressing the brain, which uncovers the effects of earlier lesions that cause damage. So the point of this is that sometimes it's hard for us to tell whether it's a true relapse or a pseudo-relapse, and that may take additional testing. And the reason is for true relapses, if they're significantly damaging, we would recommend using high-dose intravenous steroids or potentially oral steroids. For pseudo-relapses, steroids aren't the issue. It's actually finding out what the cause of the worsening is and correct that. And that might be a bladder infection, it might be a change in medication or something else. The important thing to remember is that relapses are most frequent at the onset of the disease. And then the number of relapses per year begin to decline. And by the time people get into their 60s, there's about 70% fewer relapses than at onset. Now, new lesions in the brain MRI are much more common than relapses. In fact, on average, only 1 out of 9 to 19 lesions actually is clinically apparent. The others are all clinically silent. And they follow the same pattern. So the frequency of new lesion formation is primarily at the beginning of the disease. So if you want to change outcomes, we really need to treat when the disease is most active. And that allows us to minimize any further brain damage, and that allows patients to have much better function later in life. So, as I mentioned before, relapse-remitting MS is characterized by relapses, and progressive MS is related to the accumulated damage to the brain that we refer to as the loss of neurological reserve. So again, the brain initially in our early life has a lot of reserve capacity, and it can compensate for many different kinds of injury that we may come across. But that capacity for neurological reserve is limited, and if we don't treat EMS in early life effectively, then patients will accumulate brain damage that decreases neurological reserve. And it's actually the loss of neurological reserve that leads to the onset of the progressive phase of the disease. In fact, the average time to onset of progressive disease is about 15 years out of onset of the MS. But over time, at least 75% of patients with relapse-remitting MS will move into secondary progressive. Primary progressive MS occurs in 15% of the MS patients and represents the onset of disease without prior relapses. This is just to emphasize what I've been saying. This is a new study coming out of Southern California, Dr. Dan Peltier's group, and they're doing MRI studies, and they're correcting the loss of brain volume in MS by looking at the contribution made from normal aging effects. And on this slide, as you can see, the green is actually the atrophy or the loss of brain volume due to MS, and the purple is that it's caused by normal aging. And this explains why progressive patients respond in a different way to the immunological therapies that we'll talk about than relapse-remitting patients. In early life, essentially all the brain loss is due to MS. But by the time people reach age 60, the majority of brain loss is actually due to aging. And because inflammation in MS decreases by age, there's a relatively small component there due to MS. So if you treat patients at age 30 with these drugs, it's very effective, and they can stop the brain volume loss, at least the more effective ones can. And patients actually tend to improve in function steadily, particularly with the highly effective therapies. But if we wait until age 50 or 60 to treat, we can cut off the part that's due to the inflammation. But because patients have used up neurological reserve, the normal effect of aging on the brain will become apparent as a slow change in function over time. This is why we need to treat as early as we can. Neurological reserve here is just, again, to emphasize that it's the ability of the brain to compensate for injury without losing function. And progressive disease, I would strongly argue, sets in when patients use up that neurological reserve. So I'm going to talk about the immunology of MS that we've understood in recent years, because it's important to understand this in order to understand the mechanism of action of the drugs I'm going to talk about. So the immune system has several different parts to it. It has just the barrier system, which is skin and saliva. Then there's the antigen nonspecific. This means that these cells respond to infectious agents or cancer or other things automatically. They've been pre-programmed to recognize certain foreign proteins or other molecules and react and attack whatever is activating them. But they don't learn from the experience, so their effectiveness is basically pre-programmed. Then there's the educable effector system, the antigen-specific one. And this is made up of cells, lymphocytes in particular, that actually when they recognize a foreign antigen, a protein from a bacterium or something, they are activated, and then they begin to mutate the way that they sense these foreign molecules by their receptors, either antibodies or T-cell receptors. And these are basically like a hand that reaches out and touches the other molecules. And when it activates or touches the other molecules, it acts like a lock and key function. If the protein that they're near actually combine to their receptors very tightly, then that activates them, and then they begin to mutate those receptors so they become more effective at binding to and attacking whatever it is their target. So they're the system that allow us to adapt to new infectious agents or new health problems. And it's that part of the system that actually causes MS. In fact, the only part of that system that's really important to MS are the B cells that you see down at the bottom. Those are the cells helping you make antibodies when you're exposed to an infection, such as a flu vaccine. And the field has normally thought that they were only secondarily involved, and that was the T cells at the top that were primarily driving the disease, which is true in the animal model. But as we've learned from all the clinical trials we've done with various agents, the real target is the B cell, and if you can prevent those B cells from getting into the brain, you can completely shut off the inflammation in MS. And so I'm going to talk about how all the therapies that we currently have B cell effect that may explain their function. A key part of the immunology that's changed in the last 2 years is that we now understand that there is a way for proteins from the brain to be exposed to the immune system in the lymph nodes. So lymph nodes are the areas where your immune cells are localized around the body, and they're there to survey whatever fluid comes out of the body to look for evidence of infection or cancer or other problems. Up until 2 years ago, we didn't think the brain was connected to the lymph nodes. We didn't think it had lymphatics, which are present in every other organ in your body. But, and that's since 1940. But a couple of years ago, 2 different laboratories identified lymphatics in the brain, which fundamentally changes our thinking about MS. And we now have good evidence that there is something draining out of the brain through those lymphatics that then can drain into the lymph nodes at the base of the skull. They're called the deep cervical lymph nodes. And we don't know why, but that generates these B cells that can drive MS. Those B cells, however, have to leave that lymph node and move back into the bloodstream and circulate back to the brain and cross the blood-brain barrier to cause disease. And so the various therapies we have various levels of impact on that process, either by inhibiting the B cells from growing in the deep cervical lymph nodes, or inhibiting their ability to enter circulation, or inhibiting their ability to cross the blood-brain barrier, or frankly just killing them. And I'll talk about each one of those as I go forward. This next slide just shows that there's a secondary step, that the B cells get into the brain, they get activated, and they then activate a cell that resides in the brain called astrocytes. And that's a part of the process that leads to damage in MS that we have not yet targeted with therapeutics. But that is our goal right now, is to find things we can add to some of our current therapies that will also move inside the brain and shut off those astrocytes, and hopefully then improving outcomes even more. So I'm going to go through these medications, and I'm going to talk to them about more as a group. So the interferons will be a group, the various copaxone formula, or various glutaminyl acetate forms will be a group, but they all have similar actions. So this slide just indicates how we've had these new medications come into the marketplace. Betaseron was the first one to be approved in 1991. Glutaminyl acetate and Avonex were next approved in 1996, and then as you can see, we've had a steady introduction of other molecules. What we see in the future for these therapies is actually mostly copycat drugs for these. There's only one unique drug coming out, and that's a drug called Cladribine, which should be out towards the end of the year. So let's start with the interferons. This includes Betaseron, Avonex, Plegridy, Rebif, and Xtavia. They're all injected by different doses and frequency of injections, but they all have almost the same effect. The second group, mechanism of action of these patients is to decrease the ability of lymphocytes to enter the brain, and they may induce a new type of regulatory B cell that helps inhibit the MS-related B cells in terms of damaging the brain. Now these drugs have other effects too, but I'm focusing on the ones that seem to be a consistent theme throughout the treatment of MS, and that is those that target B cells. From an effectiveness standpoint, this drug only decreases relapses by about 30%, and they don't tend to prevent onset of progressive disease, and they have almost no effect on preserving brain volume. So with this class of drugs, they may decrease the relapses somewhat in the inflammation in the brain, but they don't give much of a chance to improve patients' symptoms. So their impact on symptoms is very low. Their side effects are primarily depression, suicide, liver toxicity, and potential effects on peripheral blood counts. And these are fairly common. About half of patients on these drugs will have these kind of problems. The next group are the glutaminyl acetates. There's now 3 different versions of these, actually 4. The 4th one just got approved a few weeks ago. And Copaxone is a branded version. The others are all generics. So these drugs can be injected subcutaneously every day, or they can be injected under the skin 3 times a week, depending on which dose you're using. These cells actually do produce B cells that are regulatory. In fact, their entire effect is through their ability to generate a B cell population that can move into the brain and inhibit the inflammation caused by the MS pro-inflammatory B cells. And this is a unique mechanism of action. No other drug does this so completely. Unfortunately, though, they also only decrease relapse by 30%. They don't tend to prevent progressive MS, and they have a very modest effect on decreasing brain atrophy. It's only about 20% at best. So again, their chances to improve your symptoms is relatively low. Their side effects are pretty mild. They have a post-injection reaction where you can feel like you've had an allergic reaction to the drug. That can cause transient chest pain. The major problems are usually related to the injection sites, where there's atrophy of the fatty tissue on the skin, which causes dimples, and it also can cause skin necrosis or infection. Teriflunomide is the first of the oral medications I'll discuss. It's a once-a-day pill that you can take. It's similar to azathioprine and other chemotherapy drugs we have, where it inhibits the ability of lymphocytes to grow, and it leads to death of those that are growing most rapidly. It has a relatively selective effect on the immune system, but it does affect other cells in the body as well, such as those cells related to hair production, etc. The effectiveness, again, is only about 30% decrease in relapse rate. In terms of decrease in disability, it wasn't statistically significant in the study, but there does seem to be a trend to slow disability progression. It does decrease brain atrophy, again, about 20%, but it was not significant in the studies. So the chance of improved function on this medication, I would say, is modest. So it may have a benefit for some patients, but it's not the rule. Its safety issues are primarily related to liver toxicity, including liver failure, which can be fatal, and potentially cancer over time. There is an increased risk of infection with this drug, and it can cause a peripheral neuropathy. Dimethyl Fumarate, or Tecfidera, is another oral medication that's somewhat more effective than Albagio. It's a pill you take twice a day. We don't know exactly how it works, but at least some studies have suggested it is also increasing some regulation effects on B cells and on astrocytes in the brain. It's moderately effective. It decreases relapse by 50%. It also decreases MRI activity by about 50% and brain atrophy about 30%. The chance to improve symptoms on this drug is also moderate. Its side effects are primarily related to its irritation of the stomach and gastrointestinal system, such as nausea, vomiting, abdominal pain. You can develop an allergy to it. It has had a few cases of PML, which is progressive multifocal leukoencephalopathy, which is related to the JC virus, which is a problem with several other drugs as well. There's also a problem with the decrease in the number of white blood cells in your bloodstream. Why this is, we don't really know. Fingolimod, which is Gilenya, and coming soon are 3 other versions of this. This is a pill taken once a day. However, the first dose of this, you need to do it in a clinic where you're going to be monitored for 6 hours. And the reason is, on the first dose, it can slow down heart rate and drop blood pressure. That effect goes away after the first 24 hours, though. This one does induce regulatory B cells and suppresses inflammation in astrocytes. So like dimethyl fumarate that I just mentioned, we have 2 drugs that actually do work inside of the blood-brain barrier. How much each site contributes to its clinical effect is unknown, but it's important and something we need to study further. It's a little bit more effective than the other drugs we've talked about. It decreases relapse rates by 60%, decreases MRI activity in that 60 to 70% range, and it decreases brain atrophy by 34%. The chances to improve symptoms is moderately high. So we do see somewhat better effect of this drug on MS in terms of recovery of function than we see with the drugs I've talked about so far. As I mentioned, side effects related to the first dose, slowing of the heart. After that, though, it does increase your risk of serious infections, particularly including shingles. It has been associated with PML, again, that's the JC virus problem. And it also can cause damage to the retina, leading to edema in the retina that can lead to loss of vision. There's a number of other effects, so it needs to be just monitored on a regular basis. But those patients that tolerate the medication seem to tolerate it well, and we do see some of them improving in symptoms over time. Alemtuzumab is a monoclonal antibody. It's also called Lemtrada. It's a drug you only get twice a year for a limited time. So you get 5 infusions the first year, so 5 days in a row. Then the second year, you get 3 days of infusions, again, 3 days in a row. This drug is a bit complicated. It attacks a protein called CD52, which is on many different cell types, including B lymphocytes. The problem with being nonspecific and not just targeting B cells selectively is that it induces rather complicated changes in the immune system, and that leads to problems related to infection, potentially cancer, but mostly related to developing other autoimmune diseases, such as autoimmune thyroid disease. About 35% of patients on this drug will develop autoimmune thyroid disease, which will have to be treated, and then others can develop other autoimmune disorders that attack the kidneys or other organs in the body. So it needs to be monitored very closely. We view this as a 4th to 5th level drug because we have 3 to 4 therapies that we think are as good as this drug, but are much safer, and I'll talk about that later. This one does decrease brain atrophy by 40%, and it decreases relapse rates close to 70 to 80%. The chance of having patients improve in function on this drug is quite high, particularly those in the relapse remitting stage. As as I said, from a safety standpoint, it has some serious complications, and so it's got what we call a boxed warning, which means the FDA thought these symptoms or these risks were significant enough that they needed to pull them out and make them obvious to physicians and patients. The next drug is Natalizumab, called Tysabri. This is also a monoclonal antibody, and it's given intravenously once a month at an infusion center. This drug blocks B cells' ability to migrate into the brain. It doesn't kill them, and it doesn't kill any other immune cells, but it does block other immune cells as well as B cells from getting into the brain, and that leads to the risk of PML. So although the Tecfidera and Gilenya medications have potential for PML, this drug has a much higher potential for PML. The other ones are in the range of 1 in 10,000. This drug can cause PML in 1 in 200 patients. So what we would argue is that it's probably not a useful drug for people who carry the virus, which is about 60% of us. But if we don't carry the virus, then it's actually a very effective drug. It's also quite safe as compared to anything else we have. So we would only use it in people who had the JC virus tested in their blood and make sure that it's negative, and we repeat that test every 6 months to make sure they stay negative. This is a very highly effective drug. It decreases relapses by at least 67%. It decreases MRI activity by 80%, and it decreases brain volume loss by 45%. In fact, on average, patients if you put 100 patients on this drug, they're improving in almost every aspect of MS, every symptom as a group. Not everybody improves, but the majority do. So the chance of improving on this drug is very high. In fact, this is the one drug as clinicians that we hear that patients say they really love this drug because it makes them feel so healthy. It also has a boxed warning, primarily for the PML. There have been a few cases of encephalitis and meningitis, and a few cases of lung infections with meningitis due to fungi. It's only available through what's called a risk mitigation program by the FDA, a REMS program. But if patients are appropriately screened and monitored closely, this drug can be used quite safely. Ocrelizumab is the newest drug approved. It was approved in April of 2017. It's in a class of drugs called anti-CD20s. In other words, this drug specifically targets a protein that is only present on B cells, with a minor exception. So this drug actually kills B cells in our circulation, but because the dose we use is quite low, we don't tend to kill B cells through all the other organs, particularly the lymph nodes. So contrary to what we expected, it's not really associated with a significant risk of infections. That may change as patients are on this medication for longer periods of time. But in terms of the randomized studies, it had actually somewhat fewer infections than Reva patients did. This one has decreased relapse rates the most. It decreased them by 80%. And it really has a dramatic effect on the MRI, decreasing new lesion formation by 95%. And it decreases brain atrophy by 45%. So the chance of improving on this medication is also very high. Like Tysabri, patients on this medication as a group tend to be improving essentially all symptoms, including fatigue and depression over time. So it doesn't occur instantly. It's usually by year 2 that patients recognize that they're better. But we've been using these classes of drugs for more than 10 years, and it has been as safe as any other drug that we have in our toolbox. The safety issues are primarily related to the infusion reactions, which are usually mild to moderate and can be managed, but you should expect to have an infusion reaction with the first 2 infusions. It's a question of risk of infections. In this class of drugs, which the older drug is called Rituximab, they're used in many other diseases, but at 4 times the dose, and they're combined with steroids and chemotherapy, there's definitely a risk of infection in those populations. But because we use it at a low dose and as a monotherapy, we don't see a clear evidence of increased infections. The one exception is hepatitis B and C and tuberculosis. If you have any infections with those, this is a relatively contraindicated drug. There is in the package a possible risk for PML, but this is because they relate this drug to an old drug called Rituximab. Rituximab is basically the same drug, works the same way, and we've used it in MS quite effectively for more than 10 years. but it's not approved by the FDA. And this drug has been used in 4.8 million people since it was introduced in 1996. And there have been cases of PML, but only when it was combined with other steroids or chemotherapies, with one exception, which is a patient who had lupus, which is also a known cause of PML. So there have been no cases of PML so far that's due to the Ocrelizumab. There have been 2 cases of PML in patients who were switching from either Tysabri or Tecfidera to this drug, but the PML was actually started before they ever got Ocrelizumab. So again, we don't have any cases of PML that we can really attribute to Ocrelizumab. So this is a drug that is increasingly being used. Rituximab, as I said, is a similar drug that's you can consider sort of generic, would be used off-label. And how that'll work out over time, I don't know, but these are 2 good agents that are options for patients. There will be other versions of it coming out over the next several years. There's at least 3 more versions that are trying to get approved. So this is from a report. This is not my work. This is an independent group called the Institute for Cost and Effectiveness Research. It's a nonprofit organization. And they basically reviewed all the literature on the various molecules, and they ranked them according to the amount of efficacy they had. And so here we're looking at the chance of having a decrease in risk of disability progression versus placebo. If you look about the 4th item down, that's Ocrelizumab. However, that estimation was based only on the phase 2 data, which was a small study done about 10 years ago. They haven't yet incorporated the data from the new phase 3 trials, of which there are 3 large studies. In our experience, the Ocrelizumab is very similar to Tysabri and Lemtrada, which are the top 2. And Rituximab, which has not had any large studies here, also is very similar to them. So the data out on them now, I think, will help change this. But still, the point is we have 4 drugs at the top that are quite effective and can be used quite safely, at least the Natalizumab, Rituximab, and Ocrelizumab in appropriately selected patients. The drug below them, Natalizumab, I didn't talk about because it was withdrawn from the market a month ago due to serious safety problems. Then the Gilenya and Tecfidera, the next one's 2 below that, and then you go through all the Interferons and Copaxons. So this is the way we classify medications when we're trying to explain this to our colleagues in the neurology realm. So again, we would argue that you need to individualize the treatment based on careful selection parameters so that you minimize the risk. From an efficacy standpoint, we don't have any way to tell who would respond better to one drug than another drug. All we know is that if we treat 100 patients with drug A versus drug B, we can tell a difference, and particularly, as I mentioned, with the Tysabri and Ocrelizumab medications in particular, we can see a clear difference from that and the other drugs. But we use the term first-generation, first-line drugs, and by first-line we mean they can be used in patients who are newly diagnosed or have never been treated with anything, and that's according to the FDA. And that includes all the various interferons and all the various glutamer acetates and teriflunomide, which is Albagio. Then we have the second-generation first-line drugs. These that came from a more modern research period, and that includes Natalizumab or Tysabri, Fingolimod, which is Gilenya, Dimethyl Fumarate, which is Tecfidera, and then Ocrelizumab, which is called Ocrevus. Then there is a third box, and these are second-line drugs. So that means that you have to fail at least 2 first-line drugs before these are reasonable. Mitoxantrone, which is chemotherapy, we really don't use anymore. Alemtuzumab, which is Lemtrada, is controversial, but in our view, its risks are so significant that it shouldn't be used until you've tried several of the other second-generation first-line drugs. As I mentioned, Ocrelizumab was withdrawn from the market. And then we also include in this Natalizumab or Tysabri in patients who are JC antibody positive. Again, if patients carry that virus, I would not recommend this medication. There's a number of other very good medications. So this just summarizes what I just said. The one thing I didn't talk about was the bone marrow transplant, which is also called allogeneic stem cell transplant. And this is where they take and identify stem cells from your blood, and they sort them out in a flow cytometer. And then they give you chemotherapy and radiation therapy to kill your immune system, and then they reinfuse those stem cells to reconstitute the immune system. So it's an immunosuppressive therapy. has the same goal as the therapies I've been talking about in terms of shutting off inflammation. However, it's currently only used in patients who have early relapse remitting stage. And the problem with that is this drug has substantial risks. It's a 3 to 6% chance of death during the protocol. Patients have significant health problems for the first year, and in a number of patients, the MS will reactivate within 2 to 4 years. So there's been suggested that this is more effective than the therapies I just talked about. That isn't true. It has substantially more risk and cost, and at this point, it doesn't, in my view, really have a role to play because we have much simpler and safer therapies to use. But nevertheless, it is out there and is available, but it was earlier thought to be useful for progressive patients, but it turns out it's not. And anybody can treat early patients and get a positive effect with our current therapies. So again, I'm not a very much of an advocate for that particular approach. It does tend to get sensationalized in the media. So this is our recommendation for the Rocky Mountain MS Center. And we have 7 neurologists and 3 advanced practitioners, and we have about 2,500 patients in our practice, and we have a lot of experience with these drugs. So we would recommend, again, starting with the most effective anti-inflammatory therapy that is safe for you as early as you can. But we would use them at any stage of the disease. And in terms of progressive disease, Ocrelizumab has been approved for progressive disease, and we also think it's probably the best for progressive disease. We would recommend that you have regular visits at least every 6 months with your neurologist to monitor for safety. And then we also recommend that you eat a healthy diet to avoid developing diet-related diseases such as hypertension, diabetes, heart disease. And the reason is not just general health, it's because if you develop, for example, type 2 diabetes, that more than doubles the chance that you're going to have disability from MS. And that's because those diseases also damage the brain and use up that neurological reserve. So you need to stay healthy and avoid other diseases to maximize your function. And we also strongly urge you to exercise. The reason is that helps you build your neurological reserve, because when you exercise, you make more connections between the neurons that you have, and that gives the brain more flexibility to recover function. So that's not just important for MS, it's important for all of us in order to minimize the effects of normal aging. So if you have questions, feel free to let us know. They can forward the questions to us later, and I can try to answer them for you. And I'll just answer some questions that we have here. So there was the one slide that I showed you was from the Institute for Cost and Effectiveness Research, and that's the one where they have plotted all the drugs in terms of how much they decrease the risk of disability. And the bottom is worse, and the top of that slide means they're better medications. The bars around them just is what we call the standard error. So it's the range, since we don't know exactly what the numbers are. But anyways, again, it was just to emphasize that there is growing consensus about the effectiveness of these medications. Then somebody asked about progress in remyelinization. There's actually been a number of medications that have been tried. There was a clemastine trial and a biotin trial, and there's also alpha-lipoic acid and statins, such as simvastatin or atorvastatin. So these medications have been shown to preserve brain volume. And in the biotin studies, there's also a suggestion that it helped improve function in patients with secondary progressive disease. So there are a number of clinical trials being developed. There's one of them already active, which is the biotin trials, which is an international study. And I expect that we'll have more of these studies. In our view, these studies should be done in combination with something like Ocrelizumab or Rituximab or Tisabri in the right patients, because we really want to shut off all the inflammation and then see what these therapies can do on top of that in terms of inducing remyelination or maybe rewiring. Another drug called Relapses also completed a multi-center study recently looking at brain volume, and it succeeded. So I expect it to go into clinical trials before too long as well. And there's a question of thoughts on Rituximab. In our view, it works the same as Ocrelizumab. We've been using it for 10 years. Its safety is also very good, as long as you're screened for hepatitis B and C and tuberculosis. And patients experienced with it in our particular practice have that basically the same experience that patients with Ocrelizumab have. So we've treated more than 1,000 patients with Rituximab, and I think right now we have over 600 patients on Ocrelizumab as we move forward. There's also a question about the Ocrelizumab in terms of PML. As I mentioned, there have been 2 cases of PML in patients on Ocrelizumab, but they were both caused by the drug that the patient were on before they started Ocrelizumab. Both of them occurred within a matter of a few months of starting Ocrelizumab, and on MRI that were done before Ocrelizumab, they were already present due to the prior drug. Another question is, do you feel that these anti-inflammatory therapy or disease-modifying therapies, as we refer to them, lose their efficacy as the patient gets older? The answer is no. What happens, though, is that the contribution of normal aging to disability is increasing. And so patients in the progressive phase will feel that they're having continued loss of function, although it's slow, over time due to that effect on aging. As I mentioned, the frequency of inflammation in the brain is greatest at onset of the disease and then decreases over time. And there's a question about whether older patients should stay on therapy. So we don't know for sure. We do believe that some patients over the age of 60 are through the inflammatory phase, and using these therapies may not be a benefit to them. So my colleague, Dr. Corboy, has a nationwide study going on looking, it's a formal study of recruiting patients that are above age 55 who would like to go off therapy, and then randomize them for half of them going off and another half staying on therapy, then look to see if the patients that went off remain the same, or if there are biomarkers that can help tell us who could do that safely. There's a question about what is known about the safety of transitioning from Gilenya to other newer DMTs, such as Ocrelizumab or Teriflunomide, which is a drug coming out in a few years. We have transitioned thousands of patients between these drugs at the top. And the key issue that we think about is that with Gilenya and with Tysabri, there's a potential for a rebound in MS disease activity beginning around month 3 after stopping these drugs. So we ended up starting whatever drug we're switching them to, particularly Ocrelizumab, Rituximab, and when we were doing starting Gilenya, we would start the drug within 4 weeks of their last dose of whatever the drug that they were on. And that turned out to be very important for Tysabri to prevent the rebound of disease activity. And the most effective therapy to prevent that rebound was Rituximab, because we had that out longer and studied it more completely. And the issue there is that in our community, there's I would say, a controversy about whether that's the appropriate thing to do, since the other drugs may have prolonged effects on your immune system that don't resolve within a month. However, we've not seen any significant complications from doing that, and we've been doing it for at least 8 years. So the question is it safe for male patients to use Tysabri and then seek pregnancy with their spouse? And the answer is yes. Tysabri doesn't affect men in terms of fertility and doesn't affect the fetus in terms of risk of birth defects or anything else. That's fine. The question is, how do I define year 2? I mean that patients have completed 24 months on treatment is the time where we most universally find out patients on our more effective therapies feel that they're improving. And then there's this concept of immune reconstitution therapy that is on the internet. MS is not a disease of a immune system that's deficient or defective in terms of its ability to react to other targets, and it's not associated with immune disease of any other organ in any significant way. So immune reconstitution therapy is an approach that has not really been studied, but so far we don't see much in the way of evidence that that would be a useful approach. So if you have other questions, as I said, send them to Rockmont MS Center and we'll try to answer them for you. And I hope this has been useful for you. Take care.
That was 45 minutes. Good. Perfect.
All right. Well, I hope that works for you.